بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه وسلم أجمعين. سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. اللهم علمنا ما ينفعنا وانفعنا بما علمتنا يا كريم. Dear colleagues, there is a group of lectures about imaging of the vascular system, and this group will include imaging of the lymphatic system, imaging of the venous system, imaging of the arterial system. We have finished with imaging of the lymphatics, including the lymphatic vessels, as well as imaging of the lymph nodes, and also we presented two lectures about imaging of the lymphoma. Then in these three lectures, we'll expose some of the facts about imaging of the venous system, and we will include imaging of the cerebral veins and sinuses in a lecture. Then another one will deal with imaging of the portal venous system, and the third one will deal with imaging of the systemic veins, including the superior and inferior vena cava. And considering the cerebral veins, we'll have some issues about the venous anatomy, the dural sinus thrombosis, cavernous sinus thrombosis, idiopathic intracranial hypertension, and finally we'll deal with dural sinus malformation. You know that the cerebral or the venous channels are located between the layers of the dura mater, and they, unlike other veins in the body, they run alone. They are not parallel to the arteries. And also these venous systems do not contain valves, and they allow the flow of the blood in two directions. They are not similar to the leg veins, for example. They contain valves and they direct the venous flow towards the heart. The draining trajectories of the veins are different from those of the cerebral arteries, and the major drainage pathways from the brain predominantly go to the internal jugular vein. Then if you look here, and we have said some of the information about the venous anatomy in the lecture of the CT and MRI brain anatomy, but we'll repeat some of the facts. This major dural sinus is the superior sagittal sinus, and this is the inferior sagittal sinus, and this is the straight sinus going to the confluence of the sinuses, then the transverse sinus, then the sigmoid sinus, and finally to the internal cerebral vein. And this is an MR venogram in the sagittal, coronal, and axial images showing the normal anatomy of the dural venous sinuses. This is the superior sagittal sinus, and this is the straight sinus, then the transverse, the sigmoid, the internal jugular. The axial image, you see the confluence of the sinuses, and this is the transverse sinus, the sigmoid, and the internal jugular. On the midline, you will see the superior sagittal sinus. In the coronal images, which are good for demonstration of the transverse sinuses, you see the superior sagittal sinus, and here the transverse sinuses, the sigmoid sinuses, and the internal jugular vein. And you should know that there is some of the anomalous appearances between especially between the transverse sinuses. One may be dominant compared to the other. Sometimes we see this finding, which is considered a normal finding. The dural sinuses are two types, the paired sinuses and unpaired sinuses. The unpaired sinuses are the superior sagittal, the inferior sagittal sinus, the straight sinus, the occipital sinus, and the intercavernous sinus. The paired sinuses include the transverse, the sigmoid, the inferior petrosal, the superior petrosal, the cavernous sinuses, the sphenoparietal sinus, and the basilar venous plexus. Then the cerebral venous thrombosis and the dural sinus thrombosis, the causes are almost similar to the causes of venous thrombosis all over the body, including the trauma and infection, sometimes neoplastic invasion, and you should know that the pregnancy itself and the post-pregnant, post-labor status and also the oral contraceptive pills may contribute to the venous sinus thrombosis. This is due to the hypercoagulable state secondary seen sometimes during pregnancy and also the hypercoagulable state secondary to malignancy. And sometimes you cannot see a definite cause in the clinical history of the patient with cerebral venous thrombosis. These are the clinical findings of a patient with venous thrombosis, including headache in most of the cases, focal neurological deficits, maybe seizures, and in a good percentage of patients, you may confront with intracranial hypertension, as I will explain later. The methods for evaluation of the dural venous sinuses include the MR venography, whether without intravenous gadolinium injection or with gadolinium injection, CT venography, and the phase contrast MR venography is less often used nowadays. But by any means, you can see the dural sinuses, and even you can diagnose thrombosis in the plain CT scan without intravenous injection of contrast. The deep system drains the following areas: the corpus callosum, the upper part of the brainstem, the basal ganglia and the thalami, the inferior part of the frontal lobe, and the deep white matter of the frontal lobe, the temporal and the parietal lobe. Parenchymal changes secondary to deep venous occlusion typically involve the thalamus. And this is very important whenever you see the cases and you see almost bilateral symmetrical thalamic lesions, whether ischemic or hemorrhagic, then you think of affection of the deep venous system, especially the internal cerebral veins. And this is the anatomy of the deep venous system. The number one is the thalamus striate vein. Number two is the septal vein, this very fine one. Then the internal cerebral veins, then the basal vein of Rosenthal, and finally the vein of Galen. All these will drain through the straight sinus to the confluence of the sinuses, then to the internal jugular vein. The deep system includes the vein of Galen, internal cerebral veins, the deep vein of Rosenthal, the medullary and subependymal veins. And these are the drainage territory of the venous sinuses, and those presented in green are drained by the superior sagittal sinus, and the areas presented in yellow are drained by the sylvian veins, while the areas presented in blue are drained by the transverse sinuses, while the gray zones are drained by the deep venous system. And CT venography includes that you inject contrast material on the same way doing CT angiography of the brain, but you image the venous system. Then if you look here in this sagittal image, and you see this is the site of the superior sagittal sinus, which if it is normal, it will be homogeneously opacified by the injected contrast material. But being thrombosed, and you see this very big filling defect within the sinus. Because the venous sinuses are intimately related to bone, then in order to see the sinus clearly, especially if it is patent, and you should have uh, uh, some subtraction techniques to remove the shadows of the bone from the image so that you can easily appreciate the anatomy and the pathology of the dural venous sinuses. Then the classic signs previously known from the CT scan before the era of MRI is that whenever there is a sinus thrombosis, you can see that the thrombosed sinus looks hyperdense in the pre-contrast scans because this is acute thrombus, exactly similar to the acute hematoma. It will appear hyperdense in the pre-contrast scans. And if you inject contrast and the thrombus will appear as a filling defect within the sinus. This is of course the superior sagittal sinus, and this sign in the contrast enhanced CT is known as the delta sign, and it simulates the delta actually. And this is the thrombus which will appear hypodense, and this is the enhancing part of the or the patent part of the sinus. Then if you look in the CT scan before injection of contrast, you will see the thrombosed sinus as hyperdense hyperdensity along the anatomic course of the sinus. And of course, you know that this is the site of the straight sinus, and this is the cut section through the superior sagittal sinus. If you inject the contrast material, you will see filling defect within the thrombosed sinus in the straight sinus and the superior sagittal sinus. And you know that one of the complications of dural sinus thrombosis is the development of hemorrhagic brain infarctions. And then if you see this appearance and you got a lesion which is hemorrhagic in one of the cerebral hemispheres, then you know that this is the hemorrhagic infarction secondary to dural sinus thrombosis. In the CT scan before injection of contrast, you will see the thrombosed sinus as hyperdense structure along the anatomic course of the sinus. This is the straight one, and this is the superior sagittal sinus or the confluence of the sinuses. After injection of contrast, you got enhancement of the wall of the thrombosed sinus, but the thrombus will not enhance. It will appear as a filling defect within the thrombosed sinus. And of course, you can see the transverse sinus here, which is totally occluded by the thrombus and the enhancement of the sinus and the sinus wall in this post-contrast image. Parenchymal changes secondary to sinus thrombosis will be due to vasogenic edema, then cytotoxic edema of the ischemic tissue, and sometimes you got hemorrhage or hemorrhagic infarction, ischemia first and hemorrhage after that. An MRI, if you have the MR venogram, then you will not see a flow in the thrombosed sinus, and the acute thrombus will be similar to the acute hematoma exactly. It will appear iso-intense and the T1 weighted image and hypointense and T2 weighted image. And if you use contrast enhanced MRI, MR venography or CT venography, then you may reach the definitive diagnosis of sinus thrombosis, especially in the acute phase. While in the subacute phase, the thrombus will appear hyperintense in T1 and T2. due to the presence of late subacute blood extracellular methemoglobin. And this is one of the values of MRI, since you can diagnose this without the need for venography or even injection of contrast material. And the CT scan, you will see the sinus hyperdense before injection of contrast. In MRI, if you inject contrast material, then you see the thrombus as a filling defect within the enhancing superior sagittal sinus. In the sagittal image, you see the sinus, there is no flow in the sinus, and in the T1 there is intermediate signal which will appear dark in the T2 weighted images, denoting that you are dealing with acute thrombus. And in this example, if you look carefully here and you see hyperdensities in the posterior aspect of the brain in the midline, denoting that these veins are thrombosed. In the T2 weighted image, they will appear black because they contain acute thrombus, and in the T1 weighted image, it will appear somewhat bright. This means that you are dealing with early subacute blood intracellular methemoglobin. And if you look here and you see the region of the superior sagittal sinus appears bright in the T1, in the flare, and in the T2 weighted image, meaning that you are dealing with a subacute thrombus, late subacute thrombus with extracellular methemoglobin, which is bright in the T1 and T2 weighted images. And in the sagittal image, you easily appreciate the high signal within the superior sagittal sinus. Then marked enhancement of the thrombosed sinus may be observed resembling a normal sinus, and this enhancement is likely to be secondary and organized thrombus with intrinsic vascularization. So if you have an MR study of the brain and you inject contrast material, the thrombus may enhance and you may got a false impression that the sinus is patent. Then the only way to appreciate the presence of the thrombus is the MR venogram, which will show no flow inside the sinus. And also the gradient sequences are sensitive to detect the acute and the chronic sinus thrombosis, because in the acute thrombus, the sinus will appear black in the T2 weighted image, and in the chronic thrombus hemosiderin, the sinus will appear black also. In order to differentiate between the blackness of flowing blood and the blackness of acute and chronic thrombi, you may use the gradient images. And in the literature, it is also reported that diffusion weighted images can be helpful for diagnosis of sinus thrombosis. But I think that if you have a good quality examination and you can appreciate the presence of the thrombus very easily, especially if you supported your exam by the MR venogram. And here, the transverse sinus on the right side appears bright in the T1 and bright in the flare and bright in the T2 weighted images, denoting the presence of subacute late subacute thrombus, extracellular methemoglobin, and you may appreciate that the sinus is bright in the diffusion weighted image and dark in the ADC map, denoting the presence of restricted diffusion. But here, it's easy to appreciate the presence of sinus thrombosis using the, uh, the MR venogram. And this particular example, you can see that the straight sinus, there is no flow in the straight sinus, and also no flow in this left transverse sinus. And the follow-up after treatment showed the presence of flow within the straight sinus and also the presence of flow within the transverse sinus. So if you look here, and you can see this high signal at the confluence of the sinuses, and this high signal in the region of the of the right transverse sinus, denoting the presence of thrombosis. And in the CT scan before injection of contrast material, you can see the thrombosed sinuses as hyperdense structures along the anatomic course of the sinus. And here, this is the confluence of the sinuses, and this is the left transverse sinus. They appear bright in the non-contrast CT image denoting sinus thrombosis. And one of the sequelae of sinus thrombosis is the development of hemorrhagic brain infarctions. Here, this is the CT scan after injection of contrast, and you see that the filling defect within the transverse sinus denoting its thrombosis. In the higher up in the parietal area, you see the hemorrhagic infarction with patches of hyperdense blood within the infarcted area. An MRI T1 weighted images, then you can see the infarct. Sorry, this is the FLAIR image, and you see the infarcted area of the brain as well as the bleeding inside. Then you remember that I have mentioned that if you are confronted by thalamic lesions, especially if they are bilateral, and then you one of the possibilities is that there is deep venous thrombosis, and at that time you should go to look within the quadrigeminal cistern for the internal cerebral veins. And these internal cerebral veins and the pre-contrast scan, they appear hyperdense, meaning that they are thrombosed. Then you can easily explain the presence of these hypodensities within the thalami, denoting venous infarcts. And these infarcts will appear bright in the T2 weighted image, will appear black in the uh, T1 weighted image, and in the ETC map, you can see restriction in the right one and the free diffusion on the left one. This is another example. Then you see both internal cerebral veins are hyperdense as well as the straight sinus. And if you look in the region of the thalami, you see almost symmetrical hypodensities in the thalamic area, denoting venous infarctions secondary to internal cerebral vein thrombosis. And this is also another example. The internal cerebral veins are hyperdense in the pre-contrast scan, and there is some sort of edema or hypodensity in the thalamic areas. And 2 days later, the patient developed hemorrhagic infarction in the right thalamic area. Then sometimes the presence of these arachnoid granulations, these are the arachnoid villi which are responsible for absorption of the CSF. They may appear as filling defect within the sinuses and should not be mistaken for dural sinus thrombosis. And this is also an example. This is CT venography of the cerebral veins. And you see minute filling defects within the sinus. These are not thrombi, but they represent the arachnoid granulations. Then he came to the cavernous sinus, and they have explained this in the lectures of head and neck imaging. The cavernous sinus is present uh, on the left and right sides of the cella, and it is intimately related to the sphenoid sinus. The cavernous sinus contains the internal carotid artery and some of the cranial nerves, including the oculomotor, the trochlear nerve, the ophthalmic and the maxillary divisions of the fifth cranial nerve and the abducent nerve. And this one, which is intimately related to the internal carotid artery, is the abducent nerve, and these are the two branches of the trigeminal nerve, and this is oculomotor, and this is the trochlear nerve. Then there is a very big venous plexus draining into the cavernous sinus, and I just put this in the lecture to know this very complex anatomy of the veins draining through the cavernous sinus. Actually, if you remember, we are um, uh, interested in the superior ophthalmic vein, which is easily seen in the orbit and reflects what's going on inside the cavernous sinus. The cavernous sinus can can be thrombosed for due to several etiologies, and idiopathic without a known pathology. Idiopathic thrombosis is seen in about 10 to 30% of the cases, and septic causes, especially the sphenoid sinus, sphenoid sinusitis, mastoiditis, epidural and subdural emphysema, meningitis, encephalitis, brain abscesses. All these inflammatory sources uh, may result in extension of the infection to the cavernous sinus. Then tumor compression, like parastellar meningioma, for example, fractures, including the fractures of the sinuses or the vitreous bone, low flow state, like in cases of congestive heart failure or congenital heart disease, dehydration and shock, hypercoagulable state, which that's seen in pregnancy or in patients receiving oral contraceptive pills or uh, after labor, and also chemotherapy may contribute for this thrombosis. Then, if the sinus is thrombosed, the classic appearance is to see that the sinus is enlarged and it is not enhancing with contrast because the thrombus appears as a filling defect within the sinus. And the internal carotid artery is, in most of the cases, is patent and sometimes is displaced inward like this. Then the cavernous sinus thrombosis is the least common. It accounts for about less than 1.5% of the cases, and in most of the cases, secondary to inflammatory etiology, especially the Staphylococcus aureus, which is encountered most commonly in these patients. The clinical presentation, similar to any sinus thrombosis, is headache, and sometimes you got focal neurological deficits and seizures. In cavernous sinus thrombosis, as I have mentioned, and you got many causes I have explained. And in the pre-contrast scan, you may not see anything in the region of the cavernous sinus, but if you inject contrast material, you got no enhancement of the sinus apart from enhancement of the intracavernous segment of the internal carotid artery. And sometimes you may see high density within the sinus if the thrombus is in the subacute phase. If you inject contrast material, the sinus may be distended or enlarged with a hypodense filling defect inside. An MRI, the thrombus or the appearance of the sinus will depend on the age of the thrombus. And the best finding in MRI is in the subacute phase, where you can see the sinus is bright in the T1 and T2 weighted images. And if you inject contrast, the sinus may not enhance. But you should know that no enhancement is not a reliable indicator, as organizing thrombus can enhance, similar to those seen in the peripheral or in the dural sinuses. And here you see the cavernous sinus is a little bit uh, uh, there is some filling defect in the sinus, and in the MRI T1 weighted image after contrast, you may appreciate also the presence of the filling defect within the sinus, denoting thrombosis. And here you see both cavernous sinuses. The left one is thrombosed. The internal carotid artery is displaced inward, and you may feel also that there may be small thrombus on the right side. And if you inject the contrast material, you see then the sinus is not enhancing, the internal carotid inside the sinus is enhancing. Then if you have a CT venogram, you see the similar findings. The sinus is not enhancing and the internal carotid artery is enhancing. And because of the intimate relation of the cavernous sinuses to the sphenoid sinus, in sphenoidal sinusitis, one of the complications is to result in cavernous sinus thrombosis. And here, if you look to the left side, the cavernous sinus is prominent and it is enhanced. And also, you see that the internal carotid artery is reduced in caliber, but is still showing some signal void denoting its patency, which is confirmed in this MR angiogram. And this is also an example of sphenoidal sinusitis and left-sided cavernous sinus thrombose. Then the fungus, especially the fungal sinusitis, if it is confronted or diagnosed in the sphenoid sinus, then you are afraid that this infection may spread to the cavernous sinus, resulting in its thrombosis. Then we came to an important issue, which is idiopathic intracranial hypertension, which is also known as benign intracranial hypertension, and sometimes is known as the pseudotumor cerebral. In this disease, you got signs and symptoms of increased intracranial tension without any masses or hydrocephalus detected on imaging. This disease is typically seen in young obese females, and if the patient had um, examination for the fundus, then you got characteristic papilledema or edema of the optic disc. A neurological examination is usually normal. Sometimes you may see six nerve palsy sometimes, and spontaneous meningoceles are not frequently seen in this disease. CSF lead like rhinorrhea or otorrhea with recurrent bacterial meningitis may be present. But how can you diagnose this benign increase intracranial tension? There are certain features on imaging and also in the clinical practice. And the clinical practice is they see papilledema of the optic disc. And on imaging, number one, there are seven criteria. Number one, the presence of slit-like ventricles. The ventricles are reduced in size, but they look normal in configuration with no evidence of mass lesion or shift of the midline structures. Then the optic discs, the optic nerves will appear tortuous, and the site of attachment of the optic disc to the globe is flattened. And sometimes, if you inject contrast material, you got enhancement of the meningeal covering of the optic nerve. Also, one of the findings is the presence of empty cella, which is seen in about 70% of the cases, and there is no evidence of brain tumor, dural sinus thrombosis, or hydrocephalus. And one of the important findings of this disease, if you have the MR venogram and you see attenuated lateral aspect of the cavern, the transverse sinuses, bilateral and almost symmetric. Bilateral smooth stenosis of the lateral segment of the transverse sinuses. This is the normal appearance of the transverse sinuses, and this segment is usually stenotic on both sides in patients with idiopathic intracranial hypertension. Then, considering the orbit, you got tortuosity of the optic nerve. This is one. Flattening of the optic disc, number two. Then, widening of the CSF space around the optic nerve. And if you look here, and you got this very characteristic flattening of the optic disc and tortuosity of the optic nerve with dural ectasia or prominence of the CSF space around the optic nerve. And in the MR venogram, you got stenosis or marked narrowing of the lateral segment of the transverse sinuses. Then in the MR images of the brain, you easily appreciate the presence of empty cella. Here you see widening or ectasia of the CSF space around the optic nerves, and you see tortuosity of the optic nerves, and you may feel the flattening of the optic disc as well. And this is the I consider this image by itself is diagnostic for idiopathic intracranial hypertension. Whenever you see bilateral, almost symmetrical, marked stenosis of the lateral part of the transverse sinuses, and this is one of the interventional techniques to relieve this idiopathic hypertension is to put a stent in this stenotic segment. It will relieve the symptoms. This is another example. You see tortuosity of the optic nerve, widening of the CSS space, and flattening of the optic disc, enhancement of the meningeal covering of the disc, and empty cella you may appreciate in the sagittal image. And also by MR venogram, and you see stenosis of the lateral segment of the transverse sinuses. And one of the good policies in patients suffering from headache and signs of increased intracranial tension is to have this MR venogram in order to exclude number one, sinus thrombosis, which is a good reason for headache, and also to see this characteristic finding, which is diagnostic of idiopathic intracranial hypertension. Finally, we came to this issue, which is dural sinus malformation, and this is a congenital arteriovenous fistula between some of the branches of the circle of Willis and the dural sinuses. And because the sinuses are expandable and they cannot tolerate the arterial pressure, the result of this malformation is a huge dilatation of the affected sinus. And this is the most typical site for the dural sinus malformation is the region of the confluence of the sinuses where some of the small branches may communicate with the confluence of the sinuses resulting in a huge dilatation and enlargement with stagnation of blood, of course. And angiography here is both diagnostic and therapeutic. This is a carotid angiogram, and you see very small vessels going to the region of the confluence of the sinuses, and there is direct arteriovenous shunting. You see the sinus is hugely expanded due to this arterial pressure going into the venous sinus. And this is a CT and MRI examinations of a patient with dural sinus malformation involving the straight and the confluence of the sinuses. And in this particular patient, the sinuses are thrombosed as well, as evidenced by the high signal intensity in the T1 and high signal intensity in the T2 weighted images, denoting the presence of subacute thrombus. Thank you very much. Alhamdulillahi Rabbil Alamin.